Everyone, welcome back to the Health Data Ethics Podcast. I'm your host, Jenny Owens. And in this week's episode, I actually want to start with a confession. Last week, Anthropic, that's the company behind Claude, published an interesting research paper on labor market impacts of artificial intelligence. And of course, I was reading because I'm a super dork. And as I was reading through the key findings, I found a takeaway that actually kind of surprised me. The paper says, and we will dig into this in detail, that the workers most exposed to AI disruption in their job tasks are older, female, more educated, and higher paid. That's me. Ooh, okay. I'm not alone in this. I'm thinking here about all of my amazing coworkers and friends and collaborators and all of the people in my network. But I was intrigued, right? I wanted to dig into this study and to really understand what does this research actually say, because there has been a lot of theoretical concern for what AI might do to the labor market. This is the first paper I've seen kind of dig into it in a quantifiable manner. And then I want to talk about how this might have implications for, of course, healthcare governance, because I think there are connections here that were not made in the paper, though, that I am making in my own brain, and I want to share with you. So let's get into it. What did Anthropic actually publish? And let's break this down a little bit. The paper is called Labor Market Impacts of AI, a New Measure and Early Evidence, and it dropped actually just last week on March 5th. The researchers, Maxim Massenkoff and Peter McCrory, set out to answer a question that has been on a lot of people's minds. Is AI actually affecting jobs, and if so, which ones? The reason this is hard is that most previous research has measured what we might call theoretical exposure. Basically, could an AI in theory do this job? And when you ask that question, the answers get alarming pretty fast, because when you blend tasks with job roles, then all knowledge work looks really vulnerable to artificial intelligence. But Anthropic, because they are sitting on usage data, was able to ask a different question. Instead of asking what AI could do, they asked what people are actually using AI to do. So they were drawing on their usage data from Claude in professional settings. They called this metric observed exposure, and they matched that with the task breakdown that they got from a previously published ONET database. So they looked at the list of tasks from over 1,000 jobs from ONET. They looked at a validated measure of exposure. So there's a paper that came out in 2023 that looks at whether a large language model could do any particular task twice as fast as a human being could. And that model is basically a 0 is no, a large language model can do this. A 0.5 is maybe with some assistance or with some integrations or with something else sort of greasing the skids. And then a 1 is, yes, absolutely, a large language model could do this more than twice as fast as a human being. And so they were able to take these two things, bump them up against their usage data from Claude in professional settings, and create a new metric that they call observed exposure. So what is the theoretical exposure? Could the task be done using a large language model? And are people doing it today using a large language model, or specifically using Claude? They only have access to data from Claude. So the gap between theoretical and observed is quite large, especially in some areas. And quoting directly from the paper, they say that a job's exposure is higher if its tasks are theoretically possible with artificial intelligence, its tasks see significant usage in the Anthropic Economic Index, its tasks are performed in work-related context. Obviously, we're not really concerned about, labor market implications of people using Claude for meal planning. It has a relatively higher share of automated use patterns or API implementation. So are people doing this repeatedly so much that they would be trying to automate it? And then do the AI impacted tasks make up a larger share of the overall role? So here is a concrete example. Computer and math occupations, right? Coding. We have all heard a lot about what coding can be done with artificial intelligence these days. Theoretically, 94% of the tasks in computer and math occupations could be handled by AI. That sounds really scary. But in practice, the actual observed coverage is about 33%. That is still significant. That is a significant impact, but that is about a third of what the theory suggested could be done. Office and administrative work shows a very similar pattern, 90% theoretical, about 25% observed. Healthcare support roles, 40% theoretical coverage by artificial intelligence, 5% observed. Actual AI adoption in clinical support work is still very early. And we're not surprised by this, right? We have all been paying attention. We know how cautious healthcare organizations are about risking patient data, about risking their very sensitive operations to artificial intelligence. So I just want to put a pin in this for the future. The research did identify occupations currently most exposed, so the jobs where AI is actually being used to replace tasks or assist with the most tasks right now. And the top of that list includes computer programmers at 75%, customer service representatives at 70%, data entry keyers at 67%, and medical record specialists at 67%. And this is not surprising if you are paying attention to the products that are being hawked in the open market, right? Obviously, Claude Code has been blazing a trail through code-related work. Customer service representatives, I do see a lot of support for automated chatbots to help voice agents to take customer service calls, so I'm not surprised to see the customer service is really highly exposed. Data entry keyers, abstracting information out of free text, at making it discrete and dropping it into fields is a perfect use for a large language model. And the medical record specialist was not surprising because, of course, I do work with groups that are trying to do things with medical records and with billing right now. So it's not surprising. The other key finding that I wanted to flag is that we don't have a measurable spike in unemployment among highly exposed workers yet. So right now, this is still a risk. It is not an impact. The impact right now looks less like mass layoffs and more like maybe a hiring freeze, especially at the junior levels. So we did see a 14% drop in hiring of workers aged 22 to 25 into these exposed roles. So the jobs are still there, but the pipeline of new people coming in is slowing down. And then there's that line that I mentioned at the top. Workers in the most exposed occupations are more likely to be older, female, more educated, and higher paid, which of course does make these jobs real prime for people who are looking to use AI to reduce their personnel budgets, right? You want to look at your highly paid individuals. Previous research has pointed us in this direction. AI actually threatens female-dominated occupations like administrative work and knowledge work, and this study does add some statistical heft to that real-world data to that argument. So I just want to be clear. I think it's really obvious. I am female. Tragically, I am older. I do not think that I can successfully pass for 26 anymore, although I do like to joke that I am 167 and nobody finds that as funny as I do. I'm not panicking about this. I think the governance work that I do is, as a whole, difficult to automate, and I'm really excited about automating the parts of it that can be automated and about offloading some of the knowledge work that I do to a tool that can be relied upon to do it successfully. So if you are a highly educated professional woman listening to this, sit with this, think about it. Let's think about ways that you might be able to use AI to actually free you up to do more of the work that is interesting and less of the work that is not. Okay, I want to take a pivot in this conversation as well. So most of the commentary that I've seen on this research is very focused on the workforce question, which is interesting. As we talked about last week with my beloved husband, Brad Owens, hospitals employ people too. Hospitals hire people too. So this workforce question impacts hospitals. So which jobs are at risk? How fast that observed exposure is growing on the chart, that is all really interesting because, of course, hospitals hire people. But I also want to call out something else. These workers, the people who are watching AI reshape their industries, maybe the younger folks whose job pipelines are drying up, the customer service reps who are watching automation come for their jobs, they are also patients. They walk through our doors into our hospitals carrying that with them. And when they read the notice of privacy practices that says that their data may be used in artificial intelligence, they are bringing that baggage with them. That anxiety, the questions, the headlines they've read, the conversations they may have had with ChatGPT in the parking garage, they're bringing all of that with them into the exam room or the OR. And this is a governance gap that I have really been thinking about a lot. We don't really account for patient AI perception as a variable when we're doing our governance. We are thinking, as we should be, about how to make sure statistically that our AI is reliable, that it's treating our patients equitably, that it is performing after deployment the same way we thought it was going to perform before deployment. But I think we need to be giving a lot more airtime to what is the cultural milieu that patients are steeping in all the time? So consider a patient who has just had a very successful interaction with AI in the parking deck, right? They're sitting there and they're thinking, okay, how do I tee this conversation up with my doctor? I'm really worried about this. Tell me how I can get this across to them in a way they're going to understand. We've had a great interaction. So maybe now they're coming in with a lot of positive feelings about AI. Maybe they will defer, maybe, to an AI-assisted recommendation over their clinician's clinical judgment. They might push back on their doctor if their doctor disagrees with the AI. That is a patient safety issue and an education opportunity for our caregivers. We already deal so much with Dr. Google. Now we're dealing with Dr. GPT as well. And we can't always meet that head on. Sometimes we may need to come alongside the patient and meet them where they're at. These patients are sitting in our waiting rooms right now. And a lot of our governance frameworks don't have a specific place to hold those kinds of opinions. There's also an equity dimension here that I think might be worth calling out. If the workers exposed to AI disruption are disproportionately in certain economic brackets, then those populations may also arrive at their, cut this is stupid. Okay. So what do I actually want you to take back to your governance work from this? So first, I want governance leaders to start treating patient AI perception, both inside your walls and outside, as a real variable. So make a genuine effort to understand, what does your patient population believe about AI before you deploy it in their care journey, or as you're designing how you're doing your education. I mean, it might be a survey, it might be focus groups, it might be like a question in your intake process, but I don't know. I think the days when we could assume patients are neutral have passed. Second, your informed consent conversations around AI can evolve. Right now, a lot of AI disclosure is written for patients who have sort of arrived in the exam room with no preconceived notions about artificial intelligence. Patients may think, I feel like increasingly, our patients come in with knowledge. They come in with preconceived notions. They come in with opinions. Our disclosure language can meet them where they are. Third, this is a training issue for our clinical staff. Clinicians need to be equipped to have conversations with patients about AI. So not just our party line of we use AI tools that are validated, monitored, we're committed to using AI in safe and equitable ways, which of course is true. But what do you do when a patient tells their radiologist, I heard AI is going to replace you? Or can't you just type this into ChatGPT and tell me what's wrong? These conversations are definitely happening, and I want to make sure that we as a health system are preparing our clinicians for them. And then fourth, as governance leaders, we have a responsibility to stay current on research like this. So not just research that pertains to our specific sector, but research that affects how people in general are viewing and thinking about and interacting with artificial intelligence. Anthropic published this paper last week. It is directly relevant to how we think about healthcare AI and our healthcare workforce and the patients we serve. So reading things a little bit outside of your lane, thinking about things, and talking about this publicly is part of the job. So in the end, what's my takeaway for you today? I would encourage you to read the paper. I will link it in the show notes or in the comments. And the next time we're talking about governance policy, I want you to add one more checklist or one more item to your checklist. What does the patient think about this AI? And what are they carrying with them when they come in the door? Thank you as always for listening to the Health Data Ethics Podcast. I'm your host, Jenny Owens. I will see you next week.